Okay, ma'am, you can start now.
Yeah. I thank Medol Diagnostics and IGCP for giving me this opportunity for talking to you on an extremely difficult subject of recurrent pregnancy loss. Difficult because we still don't have one single test that can actually give you a reason why this happens, and also because, in spite of doing so many tests, there is a huge emotional factor and stress factor for which we have no reason, and we don't have a single parameter in counseling that will work. And anything and everything under the sun will work or not work with individual couples. So, since that is the opening statement that I make, we will start with the very beginning and talk about what would be the definitions of recurrent pregnancy loss. Eshrey has defined the recurrent pregnancy loss as more than two early pregnancy losses, which includes biochemical pregnancies and pregnancies of unknown location. Pregnancy loss is used as a general term, and
I'm
early
sorry,
embryo.
I'm sorry. Excuse me, मैम एक्चुअली प्रॉब्लम ये है कि आपकी स्क्रीन ना फुल नहीं आ रही हमें पीपीटी की
Pardon?
पीपीटी की स्क्रीन है ना आपकी वो फुल नजर नहीं आ रही हमें
You?
एक बार मैम दोबारा करके क्लोज करके दोबारा खोलना पीपीटी
Abhi? Is it
अभी
coming now?
कैन यू डू इट अगेन फुल स्क्रीन
Hmm? Abhi?
मैम ऑन द टॉप देयर इज अ होम बटन यू सी ऑन द स्मॉल आइकॉन देयर
Hmm?
on the top. Yeah, next one. Press this. Press.
Yeah?
No, it's not coming. Do one thing. You can cancel this PPT. Just you speak. We will adjust the PPT later on. This is what we can do.
Just the PPT?
Yeah. 1 minute. Okay. Just 1 minute. ओके मैम पीपीटी आप शेयर कर दो अब हम छोटे से शुरू कर लेते हैं कोई इशू नहीं
कौन सा से?
हाँ शेयर करना पीपीटी आप दोबारा से
यहाँ से?
हाँ जैसे हमने पहले शेयर किया था
यहाँ से?
शेयर ऑन द स्क्रीन पीपीटी
ठीक है.
Ma'am, can you share the screen with me?
Can I share the screen? Yeah. Okay.
Yeah.
I'm sharing this.
This one?
Hmm? Okay. He wants this thing shared.
PPT share ಮಾಡ್ತಾ
It's here.
But we've shared it now.
Ma'am, it's okay. If you share a full screen, that's fine. Just minimize this and open the PPT.
Minimize this, is it?
Yeah. Open the PPT, just minimize this screen.
It's here.
So he has to minimize this.
No, on the top. It's an inner screen.
This one. Minimize this.
Open the
Just
PPT.
the PPT.
Download.
No.
Download the
ಇದಿಲ್ಲ.
this file. Can you see?
Yeah.
The first one. The first one, the very first one. I guess it says this one.
Can you try to do a full screen now? Let me check. Full screen.
Is that okay?
Yeah. Now it's fine. Now you can start.
I can start now?
Yeah, yeah. Now it's fine. Thank you.
Sure. Okay. So I'll start all over again.
And you can start from the start, from the first slide itself. Now it's totally
Okay.
fine.
Sure. You can still see my face?
Yes, ma'am.
Hello?
Yes, ma'am. I can see you. I can see your face.
Okay. Thank you, Medol Diagnostics, for giving me this opportunity and for IJCP for kindly hosting this program. And it is my pleasure to take on a difficult subject like recurrent pregnancy loss. I say difficult because we don't have a single answer to this problem clinically or biochemically or radiologically. And I think this is going to be an enigma at the start of my lecture, and I hope I can make this enigma less confusing and with more consensus at the end of my talk. But I would like to tell you that I don't have any magic solutions. But let's start at the very beginning and looking at what the definitions are. Eshrey says that more than two pregnancy losses, or even equal to two pregnancy losses, which includes biochemical pregnancies and pregnancies of unknown location. Pregnancy loss is used as a general term, and early pregnancy loss, the first trimester pregnancy loss, and second trimester pregnancy loss when gestation specific reference is needed. However, when we look at the RCOG, they just categorically say three or more consecutive, that's the word, consecutive, one after the other pregnancy losses. But the American College say something different. That is, two or more pregnancy losses confirmed by ultrasound or histology, not necessarily consecutive. So, if we have to look at the incidence here, recurrent, that means one after the other, repetitive, recurrent pregnancy loss occurs in 1 to 3% of all couples trying to conceive. The risk of pregnancy loss increases with each loss from even as much as 11% and can go in as far as nulligravida to as much as 40% after three consecutive pregnancy losses. That means almost 2 out of 5, and that's quite a lot. And that is after three pregnancy losses. But the prognosis worsens with the increasing maternal age. The incidence of recurrent pregnancy loss is higher among the infertile women. Now, this is something that one needs to understand. It's not only a physical component, but the psychological impact. It's mind over matter. If it doesn't matter, then it won't mind, but it does mind. And therefore, what is the psychological impact? Pregnancy loss is a significant negative life event, and such recurring events may intensify the grief experienced and a sense of personal failure. Childless couples and women may face discrimination, stigma, and ostracism. Therefore, appropriate support should be offered to reduce the associated psychological burden. Couples want the medical team to know their obstetric history and to provide compassionate care, show understanding, take them seriously, and show empathy. And clear information about the cause of miscarriage, the likelihood of recurrence, the tests required, and treatment that could prevent a recurrence. Therefore, studies have most focused on women, so there is a need for studies on the emotional impact of recurrence in pregnancy losses on men too. So, what could be the risk factors? The one important risk factors that we are not so familiar with are the genetic factors. The structural chromosomal anomalies are seen in approximately 2 to 5% of recurrent miscarriages. Most common balanced reciprocal or Robertsonian translocations. Others include chromosomal inversions, insertions, and mosaicism. Low maternal age at second miscarriage, history of more than 3 miscarriages, history of more than 2 miscarriages in brothers and sisters, and history of more than 2 miscarriages in parents of either partner all increase the probability of a carrier status. But we can't forget the epidemiological factors or the thrombophilias. When we talk of epidemiological factors, we have to look at the advanced maternal age, and that would be above 35 years of age, and the number of previous miscarriages and advanced paternal age of more than 40 years. And looking at the lifestyle habits such as maternal smoking, alcohol consumption of more than 5 units per week throughout pregnancy, or over 3 per week in the first trimester. Caffeine consumption, and that's coffee, 3 to 5 cups per day, and obesity, illicit drug use like cocaine. What about thrombophilias? Acquired thrombophilias, antiphospholipid syndrome, hyperhomocystinemia, acquired protein C resistance, inherited thrombophilias, antithrombo 3, protein C deficiencies, protein S deficiency, and factor 5 Leiden, prothrombin gene mutation, common and weakly thrombogenic. What is antiphospholipid syndrome? It is almost accounting for a fifth of these thrombotic episodes. Yes, dear friends, yes, it is a fifth of cases. Most important treatable cause of recurrent miscarriage. Recurrent fetal loss typically occurs in the second trimester and may occur at any stage of pregnancy. Only a 10 to 15% of women are antiphospholipid antibody positive. The probability of finding APL in prenatal exams is less than 2%. So, what can be an antiphospholipid syndrome diagnostic criteria? At least one clinical criterion, that is, either a previous thrombotic event or gestational morbidity, and at least one laboratory criterion confirmed positive APL at more than 2 separate time points with a 12-week minimum interval. On my right hand, you have a table which will suggest to you the international consensus classification criteria for the antiphospholipid syndrome, and that is the APS. This has been as recent as the fertility sterility of 2012. Now, looking at more of the anatomical factors for the recurrent pregnancy loss are the uterine factors, and that could be in the form of abnormal uterine anatomy, in the form of congenital and malformations, septate uterus, double uteri, arcuate uterus, acquired anomalies like fibromas, uterine polyps, intrauterine adhesions. Women with septate uteri are more likely to miscarry in the first trimester, while those with an arcuate uteri have more second trimester miscarriage. Cervical incompetents are more likely to have a second trimester miscarriage preceding a spontaneous rupture of membranes or a painless cervical dilatation. The lining of the uterus, which we call as an endometrium, gives an impairment in the endometrial quality and may affect implantation and placentation, impaired proper embryo development, miscarriage, and recurrent pregnancy loss. Chronic endometritis in 10 to 15% of the infertile women and 40% of endometrial cases. Looking at the hormonal and metabolic factors, hypothyroidism, antithyroid peroxidase antibodies, Hashimoto's thyroiditis are at risk factors. Treated thyroid dysfunction is not a risk factor for recurrent miscarriage, but uncontrolled diabetes is a risk factor. Hyperprolactinemia may be associated with recurrent miscarriage, and that loss is because of the alterations in the hypothalamic pituitary ovarian axis and impaired folliculogenesis and oocyte maturation and or a short luteal phase. What about the infections? I'm sure you know there are infections in terms of bacterial infections, protozoal infections, viral infections, and whatnot. But that would account for almost 0.5 to 5%. Infections include Listeria monocytogenes, toxoplasmosis, rubella, herpes, measles, cytomegalovirus, coccidiovirus, mycoplasma, ureaplasma, chlamydia, and trachomatis. As most of these infections are isolated events, there is apparently limited role for infections as an etiological factor in recurrent pregnancy loss. Proposed mechanisms for infections causes of pregnancy loss include a direct infection of the uterus, fetus, or placenta, placental insufficiency, chronic endometritis or endocervicitis, amnionitis, infected intrauterine device. But so far, we have been talking only about the female factors. Please understand that it can also have male factors. Standard semen parameters, including sperm morphology, are not predictive of recurrent pregnancy loss. Abnormal DNA fragmentation, advanced paternal age, or exposure to correctable environmental factors such as exogenous heat, toxic exposures, varicose or increased reactive oxygen species in semen, or ROS as it is called. Unexplained recurrent pregnancy loss where no apparent causative factor is identified in over three quarters of the couples. Chances of future successful pregnancy in such cases can exceed to over 50 to 60% depending on maternal age and parity. So, when we actually look at the diagnostic evaluation, one has to understand, can we identify the underlying treatable condition to try to improve outcomes? History taking is important. Previous obstetric history, history of any preterm birth, gestational age, bleeding tendencies, have to be emphasized and has to be recorded. Physical examination, general physical assessment, including examination for signs of endocrinopathy, is extremely important. So also pelvic organ abnormalities, uterine malformations, and cervical lacerations. In all this humdrum, we always forget the mind of that particular couple. Always, always, as an integral part of a screening program, screen for depression. Because depression is the one thing that many of us fail to recognize. So, make sure that if she needs a counselor, this is the time for you to put them across to a counselor or a psychiatrist. What about the antiphospholipid antibodies? Of course, you need to do that. The indications would be three or more unexplained spontaneous abortions before the 10th week of gestation, after excluding maternal anatomic or hormonal abnormalities and paternal and maternal chromosomal causes. Single unexplained loss of a morphologically normal fetus at more than 10 weeks gestation. Two positive tests at least 12 weeks apart of either lupus anticoagulant or an ACL, IgG or IgM in moderate to high titers, that is more than 40 G per liter, confirms the diagnosis. Screen for inherited thrombophilias like factor V Leiden and prothrombin gene mutations, protein C, protein S thrombin deficiencies. If personal history of venous thromboembolism due to non-recurrent risk factors, example surgery, or a first degree relative with a known suspected high risk thrombophilia, women with any unexplained stillbirth and more than a second trimester loss, uterine factors, then hysteroscopy, laparoscopy, MRI, and a 3D ultrasound, transvaginal or transabdominal ultrasound, sonohysteroscopy, and hysterosalpingography may be warranted. Abnormal chromosomes, while chromosomal analysis of both father and mother is mandatory. Abnormal embryonic karyotype, chromosome analysis of the products of conception, and endocrine abnormalities requires testing for diabetes, thyroid functions, and prolactin metabolic syndrome PCOS as suggested by the history and physical examination. The torch screening, however, has been very controversial, and perhaps in the 90s and late 80s, it had been very rampant to test all these people for torch. However, now, unless there is anything specific to test, I don't think that torch infection has any role at this point of time to test, and when it is tested it has to be very specific in cases of toxoplasmosis, because most of the women girls are being given vaccination for rubella, and so they are always vaccinated for rubella, so it's unlikely that they'll have it, and most of the ones that have herpes are not likely to respond with the early miscarriages. Infections caused by torch agents in women are usually asymptomatic and chronic. Torch infections are associated with recurrent abortions, IUGR, IUD, preterm labor, early neonatal death, and congenital malformations. However, previous history of pregnancy wastages and positive serological tests during the current pregnancy helps to reduce adverse fetal outcome. However, even with a positive IgG test, it still does not confirm that the woman has an active infection in this pregnancy. So, if we have antibodies of IgM and IgG against toxoplasmosis, rubella, cytomegalovirus, herpes simplex 1 and 2, we need to look at it much more closely. Absence of antibodies indicates a negative result, while presence of antibodies indicates a positive result. A negative result for both IgG and IgM indicates no previous or recent infection. The positive result for IgM and negative result for IgG indicates a recent infection. A positive result for IgG and a negative result for IgM indicates an old infection which may have occurred already or a vaccination. So, if we have to look at the suggested diagnostic evaluation of recurrent pregnancy loss based on etiology, let's look at the summary of the chart on the right hand side. If you look at the genetic thing, you look at the parental karyotype. If it's anatomic, then you look at the HSG, an office hysteroscopy, and if you look at the endocrine, you look at the thyroid, the prolactin, the insulin resistance, and perhaps the antithyroid antibodies. If it's infections, no evaluation recommended unless patient has evidence of a chronic endometritis cervicitis on examination or is immunocompromised. Autoimmune anticardiolipid antibody levels IgG, IgM, lupus anticoagulant. Non-APS thrombophilias, homocysteine, factor V laden, prothrombin promoter mutations, and activated protein C resistance. So, you have a very busy slide here, which is the evaluation of recurrent pregnancy loss, which has been agreed by the RCOG, ASRM, and the HRA recommendations. And if you put them all together here, the HRA has the recent recommendations here, which really tells you a summary what I have spoken to here to you all along, but it only gives you that summary. Finally, it has to be individualized to each individual case. Nothing can be painted with the same brush. We have to take the patient as a whole. You can't take it to be an organ specific thing. We have to be very clear that when we are taking all these things, do not forget that beyond all this, stress can be a very important factor. You may find nothing wrong with the patient. It could only be a stress factor that has not allowed her to go through the complete pregnancy. And even after leaving all of you, she can still go and have an absolutely normal pregnancy. And believe me, you could have done the maximum number of tests and she would still not have continued the pregnancy. But the moment she has left your clinic and she's gone away from the stressful situation at home and in your clinic, she will go ahead and have an absolutely normal pregnancy and a normal delivery. And I have seen many such cases happening. So, the treatment here would be counseling of the couple, investigations and the outcome of investigations, treatment plan and outcome of treatment, psychological support before, during, and after is absolutely important. Give strong psychological support to the couple. Genetic counseling, couples with abnormal karyotype detected during the screening period should be referred to a clinical geneticist where available for detailed counseling about outcome of future pregnancies. Lifestyle modifications including weight reduction, exercise, cessation of smoking, limiting alcohol consumption cannot be overemphasized. So, if you looked at this again is a busy slide, but again is a summary of what I have been telling you on all my previous slides. So, the therapeutic interventions for recurrent pregnancy loss based on etiology is all put on this slide for you to see. So, this is again a continuation in the treatment of recurrent pregnancy loss, comparison of all the guidelines that you have from the X-ray, from the ASRM, and the RCOG, and all other guidelines. So you have specific treatments for a few of the problems, but you don't have treatment for a lot more problems that you may think that you have cracked the Da Vinci Code. But, my dear friends, we still have to learn much more, and that is empathy, compassion, and counseling. That needs to be understood. That a lot of empathy and concern has to be given to the woman. It's not easy for a woman to face an abortion. It's not easy for a woman to face that loss. So please understand, it's not so much of a physical problem. It's more of a counseling that needs to be done in this case. And we have to all help this woman to get her status back in society. She should not feel incomplete. She should feel complete. She should feel the complete woman that she is. And just because she has this abortion, she should not feel that she is less of a woman. And when you make her feel that complete, there's a lot of neurotransmitters in the brain that sort of, equalizes within itself, which no medicine can do. And I'm sure the doctor has that power, that everything cannot be cured by medicine. So, tender loving care, TLC. That's not put on my slides, but believe me, that's the strongest medicine that you can give to the patients. Whatever number of tabular columns I can put over here, but that's the biggest tabular column that I can give you throughout my slides. If I tell you that you can do it and this can happen, many of these people will be able to conceive without any of these supports, particularly the unexplained recurrent pregnancy loss. So, treatment of recurrent pregnancy loss where there is no cause will really be supported by counseling, counseling, and more counseling. So, the overall prognosis is going to be good. Individual prognosis depends on the underlying cause and the number of prior losses. Correction of endocrine disorders, antiphospholipid antibodies, anatomic anomalies have the highest success rates. Success rates in patients with cytogenetic basis for the loss is 20 to 80% depending on the type of abnormality present. So therefore, prognosis depends on the origin of the problem. So evaluate the couple after more than 2 pregnancy losses to determine the cause of repeated miscarriages. Refer to reproductive specialists. Etiologies include antiphospholipid antibody syndrome, uterine anomaly abnormalities, hypothyroidism, uncontrolled diabetes mellitus, parental chromosomal abnormalities. 50% of recurrent pregnancy loss remains unexplained, and that's where the tender loving care comes in. Diagnostic evaluation includes assessment of uterine anatomy and, of course, antithyroid antibodies and the protein C and S and the antiphospholipid antibodies, factor V prothrombin gene mutations, and I am not really convinced about the torch infections. Antenatal counseling and psychological support. Treatment is directed towards etiology, and prognosis depends on the etiology. So, in my final slide, I would like to tell you that if you are able to look at the patient as a whole, as a mind and body, and not look at her as a uterus and a pair of ovaries, I think I would have been successful in convincing you people that my lecture today on recurrent pregnancy loss was extremely worth it. Thank you very much. Finish?
Okay, ma'am. Thank you.
Was that okay?
Yes, ma'am. All okay.
Thank you.
Thank you. Thank you very much for your time, madam.
That's okay. No problem.
I will edit it and then I will send it to you. Before again we are going to telecast this. That time I will send it to you for after your approval. We will telecast it again.
Sure, sure. No problem.
Thank you.
Thank you.
Thank you very much, madam.
And
Thank you.
sorry for all that delay. Yeah.
No,
It's
no,
okay.
it's okay. I can
Okay.
understand. Thank you.
I hope I made it worth for
Yes,
making.
super. Excellent, madam. No doubt about it. Thank you.
Enjoy your evening, ma'am. Enjoy your evening, Nanda.
You know why? Because I don't want to make him hate, but at the same time, I don't want to be taken for a ride.
Hmm.
And I don't want to be sold on somebody else's crap. Okay? Like food was okay.
Food eating. I'll just check for you.
That's fine. Now I don't have to. I thought I would do this.
ಹಲೋ 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 ಒಂದು ನಿಮಿಷ ಇರು. Can you hear me? ಹಲೋ ಹಾಂ ಸರಿ ಹೇಳು. ಇವಾಗ ಬಿಡ್ತಾ ಇದ್ದೀನಿ. ಸಹನ ಸ್ವಲ್ಪ ಶೀಸ್ ಗೋ ಟು ದ ಮಂತ್ಲಿ ಇಚ್ಚಿಂಗ್ ಗೋ. ನಂದು ಲೇಟ್ ಆಗುತ್ತಲ್ಲ.